the Director General for those very lucid comments. I'd like to open this for comments and for discussion. So we take that right now. I think first, foremost, I'd like to, a short while ago, we had a number of past presidents of the West African College of Surgeons, chairmen of faculties who have, over the years, steered the program of training and certification in our college. Some are still around. I'd like to invite the president of the Ghana College and the CONFÉRENCE if they have any comments to make on this. Professor John Mears, you have, is there a microphone? Can we get him a microphone? Otherwise, you may need to come down here. Professor Jani, there's no microphone. You two need to come down to make a few comments from the point of view of what CONFÉRENCE is doing.
Thank you very much, President. And thank you, Dr. Maku, for your presentation. It was excellent. We at the Ghana College have also moved, and we believe we are doing the competency-based training. But certainly, there are aspects which we haven't done very well yet, and that is assessment, formative assessment along the way. We haven't broken it down to the specific issues like managing trimalleolar fracture. But when I finished also, as the president of the West African College has said, some of our past presidents and trainers, Professor Champong, I saw him earlier, he's around, and he is willing to, I would ask that he should make some comment for us because of his immense experience in this area. But I am saying that for the formative assessment, we may have to really go down and do a lot more assessment, very specific things. So far, we are virtually doing a global assessment at certain points during the training. But we will have to move forward. And then also, I saw a 360 out there. Unfortunately, one could not read it too well out there. It looks like an assessment of the trainers also by the trainee, which we have started. But how to really get it done thoroughly and properly, I'm not sure we are there yet, but we are getting some information and feedback. And certainly, that feeds well into the trainee who is weak, and so as to correct it. Right now, we have elements of the time-based situation. When you do not pass your exam at the first time, you have 6 months in the training institution where you are, and after that, you have to move out and then come and take the exam later on your own. Once again, we can sharpen that by putting in programs for such people. The aim is to produce that person as a competent surgeon. And so leaving him to himself, I don't think is good enough. But these are areas we are moving on in there. Now, if Professor Champong is around, I would ask him whether he would want to make a comment. Yeah.
Thank you very much. I think you make a note of some of this so that you can make comments subsequently. Let's have Professor Jani Pankaj give us some comments from the College of Surgeons of East Central and South African States.
Thank you very much, King Tonayawe. It's an honor for me to address this, primarily because I've been a little involved with this over the time that we have been looking into this. I think this is fantastic. This is the Uberization, if I can label it that way, of training in surgery, you know. And this is the way to go forwards, because the original papers of this came from Holland, if I believe correctly, and I've been looking into this a bit about entrusted activities. Because as the name suggests, that is the thing to do. If you want a surgeon to be able to do a procedure, can you entrust him with that professional activity? Now we come to the nitty-gritty of this. There's a lot that goes into the investment of establishing this. And the problem that we see at the present moment, and this is not your problem, this is our problem, is that our priorities are a bit different from the priorities in the West. For example, as you mentioned, an ankle fracture. It's common here, but we would like to have entrusted professional activity for hernias, you know, for appendicitis, for resection anastomosis, things like that, the common emergency and essential surgery procedures. Excuse me. So I think since Canada and Toronto, University of Toronto especially, has moved along quite forwards with this, my request would be, and COSECSA is at the present moment in discussions with the Canadian Association of General Surgeons, CNIS, and we are trying to partner. But this is the area we really need to request your assistance in, because the reasons being, there's a lot of investment required in preparing these documents and procedures and how to go about it, and it would be Greek for our surgeons, our trainers, to start this. It would take a year or two for them to become familiar with trying to create the steps of the map and all that. So that's the first thing that we would request, but along the lines of what is pertinent for us, meaning the DCP3 list of 43 emergency and essential surgery procedures, or the ICES, International Collaboration for Essential Surgery list of 15 surgical emergency and essential surgical procedures, which are bedeviling Africa. I mean, this is our big problem at the present moment. How do you train our general surgeons in these emergency and essential surgery procedures? So could we partner with you and say, let us prepare the roadmaps and whatever you mentioned for EPAs for this training. Now, this is really exciting because the problem is time. As we talk here, we lose one female in this world every hour because of pregnancy-related complications. We lose 10 because of trauma, various types of trauma. So time is of essence here. When I was talking to our minister, I'm going to talk about this tomorrow, we need 771 surgeons to be trained in Kenya yesterday, because we have 257 district hospitals. 90% of our district hospitals do not have a general surgeon. 90% do not have an OBGYN, all right, or an anesthetist. We just did a surgical capacity study in Kenya. So they're saying they want this, and they want it as fast as possible. And we put the ducks in line and said, if we have 23 training centers, which we have now created along the US lines of hospital-based training, you know, it will going to take us 10 or 12 years to produce the 771 surgeons. However, if we get help from Canada, I'm using Canada as the big term, okay? And we can succeed, it would produce these surgeons who can do the emergency and essential surgery, general surgery, really typically in the district hospital level, to save an immense number of lives in the short period. And the one thing that I want to mention lastly is that this will lead to the next level of trying to identify from the medical students the correct people who will go through this process and come out as fast-track surgeons. Thank you very much.
Thank you very much, President of COSECSA. Dr. Aku will keep making a few notes, and we'll give him time to respond. Are there any other comments from the floor? So that before I make mine from, before, can you give him paper from that side? We'll give it. Oh. Before I give you information on what the West African College of Surgeons has been doing. Yes. I'd like us to make the comments very brief. We give special attention to the presidents of colleges, but the rest of us just go straight to the point.
Okay, my name is Dr. Peter Baibe. Besides being the fellow of the College of Surgeons, I'm also the chairman, Faculty of Obsangani, National College in Nigeria. We had already decided, that we're moving along this line. So I was quite happy you know, to get to listen to this presentation. But one major challenge that I noticed, because I'm familiar with the Dutch model, I read quite a lot about it, looked at the Australian, New Zealand program, is the issue of monitoring. The costs of monitoring, because you have both,
speak directly into the microphone.
Yeah, because you have both in-program monitoring, assessments within the training facility, and then you have monitoring by external agents, people from other facilities or from the general training program, you know, the National College or African College or whoever is overseeing the whole program. And that's where I find a big challenge for us, because there are multiple points at which you're monitoring. Who funds the journeys? Who funds the materials or the equipment or whatever you're going to use to monitor these persons? Especially because he acknowledged that even in Canada, that not a low resource setting, that funding for the training program is a problem. So I see that we're going to have to really find a collaboration which might involve both the public sector, the private sector, whatever, in our low resource settings. You know, if we're going to achieve it. Because if you're going to have multiple points, and you're going to have people traveling from Lagos to, let's say, Calabar, or Lagos or Abuja to Kaduna in Nigeria, for example, how do they go there? Who pays? Is it the hospital? Is it the candidates? Is it the government? That's a big challenge. But it's something that we must look at critically. So that when we document our program, you know, that question is thought through, so that we don't start something and have to find that we're not doing it well. Thank you.
Much. Any other? At the back, yes.
Thank you very much. Bichri Technologies. I was also a former Minister of Health, Nigeria. I'm only going to talk about certain basics, what I consider basic surgical skills. I think time has come for us to be more practical if we are to make progress. If a country like Mozambique, at least I was told when I was minister, we had a meeting of ministers of health from all over Africa, and the Mozambicans told us they had to train some nurses to be able to do procedures like cesarean section. So why can't we now make it compulsory for all house surgeons to be trained to do cesarean section? Thank you.
Thank you very much. Yes, Dr. No from Cameroon. That's my sister from Cameroon. Please.
Thank you, Mr. President and moderator. I'm Ngononga from Cameroon. I just have a comment. Dr. Marco asked a question. Is that competency-based training suite Africa? Africa faces a lot of challenge. We were talking earlier about planning in surgery. We don't even know how much surgeon we do know in our country. We have not covered the whole area with surgeon. You just heard from Kenya. We have a lot of challenge. Now, the main question that we should ask to ourselves, what is important? How are we going to move? There's something that we do, which I think is not good personally, to always try to do as they do in the West. West have a lot of things that we don't have yet. We don't even have the basic. We don't even have the same education. We're talking about quality, quantity, lack of everything almost. I think that's what we should ask ourselves whenever we want to follow something, because many things are good, but what is good for Africa? Thank you.
Right. So, okay, let's take the last comment for this segment from...
Thank you, Mr. President. I'm Aminu Muhammad Balarabi from Nigeria. I'm happy to have listened to this presentation. I think it's the way forward. And I also believe the college will look into this direction. However, I have a question. Looking at the transition from the conventional exam in West African College of Surgery to the OSCE exams, many trainers are reluctant in accepting the new system. Is it going to be the same thing with this competency-based medical education being introduced in Africa? I would like the presenter to help us highlight how to make the trainers themselves accept this new system of teaching so that they can pass it on to the trainees. Thank you.
Let me thank all the contributors so far, and I would add a little bit before we continue. The past presidents of my college are out, but I'd like to tell you we have a historical perspective to the examination processes. There has, of course, as Dr. Marcos began his lecture, you get to know that the issue was that you will be able to be, competence is the core of surgical training. If it's not a theoretical business, it's about practice. So you really have to have knowledge and competence before you can practice as a surgeon. And the science and then the art. And the art takes time, even though it's based on science. We started off with a 4-year training program. And in course of time, we discovered that it wasn't as the social factors began to affect training, and there have been plenty of social factors. Unfortunately, they are coming every day, a flood of them. We had to begin to and then of course the second problem was we needed to increase the number of surgeons in training. From a patry 10, 20 in the sub-region, now we have over 4,000 training positions in the sub-region. In many instances, the hospitals have only marginally improved on the capacity to take more. So we felt there was a need to lay more emphasis on the competence. And we looked at competence in terms of the exposure, the skills acquired, assessment of those skills. And in the end, we thought there was need to improve, have a sort of a structured approach. And this brought about what we call the logbook. The logbook shows us how much you have been exposed to surgery and how much competence or experience you have acquired in practice. That meant that without meeting those requirements, in that duration of training of 4 years, we had to begin to make increase in the time to be spent in training, moving from 4 years to 5 years, and now in 6 years. And for some of the subspecialties, like neurosurgery and cardiothoracic surgery, it's even up to 8 years or more. That has not totally addressed, increasing the duration has not totally addressed the issue. And so we moved to another step to see how can we train, move from the laboratory before coming to humans. And that's a very important aspect of the concept of acquiring competence. And so we have the basic surgical skills, and in various disciplines we move to advanced surgical skills, which are basically laboratory-based, including laparoscopic surgery. And we have a very fantastic center in Accra, Ghana, that deals with American College of Surgeons, helped the West African College to set up. And we have insisted now that basic surgical skills have to be acquired to be able to make progress in the training program. And so we have to join team with the Edicon and Johnson and establish a number of surgical skills centers in the sub-region. The concept has been to ensure that at every level of exit in the program, and we have 3 levels of exit in our training program. The first, of course, being the membership level of exit. And we have a diplomate level of exit and the fellowship itself. And in each of these, they have restructured our curriculum in the past few years and in such a way that there are endpoints. This level of competence must be acquired before you can be exited from the program. And to get this done, you have some aspect of laboratory training to enable you to move from the table, from the bench to the operating table. So that has enabled us to meet two very important things. One is to increase the number, increase the number of trainees in the program, and at the same time be able to instill some competence that can be improved upon as they go further in the training. And I like to say this is not perfect. For example, we have 128 training stations, accredited training stations, and we are far short of basic skill centers in the sub-region. So we haven't reached there yet. The second thing is that in the specialized areas, for example, we talk about temporal base bone dissection. There aren't too many centers that can offer you that kind of skills before transferring to the operating room. And so these are a few challenges. And then we come to the specialized programs, advanced surgical skills, laparoscopy skills, and so on. Again, this is an area that we think is very important. It is for about 20 years now that we had our center in Accra, Ghana, for advanced surgical skills. And so we are moving from that now to see how we can set up simulation centers within the sub-region. Fortunately, at least 2 have sprung up in the sub-region, and we are hoping to spend more time doing so. But then we need to have a critical mass of trainers also. And one of the things we are doing in this meeting in conjunction with the Royal College of Surgeons and Physicians and Surgeons of Canada is we will start off a training program on skills acquisition and stimulation. In the meantime, we will have only a very few number of people involved, fellows specifically, who will undergo this training. And then we hope to duplicate and replicate that in various training centers across the sub-region. So in the final analysis, every training institution we have its skills center. And I can tell you we have a central system of monitoring to ensure that those skill centers are operating as they were patented. So we accredit the skill centers as well. And we train the trainers. And so we expect, and usually this is what comes out, they will duplicate what is expected. So we have changed the pattern of examination. The whole concept is to also see that we are not just testing knowledge, but we're also testing the competence. I know that the OSCE system is an expensive system to run. But you see, it reduces a number of shortcomings that are human, which make the whole process of assessment much more objective. So we are gradually deploying that. We are transiting from the conventional form of examination to the OSCE-based examinations. And we're doing that at certain levels. We have not deployed that for the final fellowship examination, and we have just migrated that now to the membership in some faculties. 1 or 2 faculties in our college are also using it for the exit program. And I want to say this. What we have seen so far is that it gives us a better, we have not gone too far, but we have better improvements in the numbers. It discriminates competencies much better than the subjective ways in which we had traditionally been using. But it is still, I should say, not really in its infancy, but in the much earlier stages. And there is definitely room for improvement. Why are we discussing all of these subjects? Because we want to, in our sub-region, the statistics for specialists, even though not completely documented, is extremely poor, very low. And we worked with the WHO, and with the WAHO, and we're able to make projections, and these projections over the years, a period of 20 years, have been quite correct in the capacity building for specialists in the sub-region. So we want to improve on our universal access to surgical management in the sub-region. And to do that, we need to scale up in two ways. We need to scale up our training programs, accredit more, train more rapidly, where these competency-based programs come in. And two, we need to, and we are working towards seeing that we scale up services. So we are scaling up manpower training, we're also scaling up surgical services. So we also restructured our curriculum to see to it that our trainees will get, and it's a hybrid from what the CONFÉRENCE uses. CONFÉRENCE trains basically mostly within where you will practice. We have been training traditionally for a long time in teaching hospitals. We are now making a hybrid program utilizing the specialized tertiary training centers in addition to rural centers. That has worked very beautifully in Ghana. So we have also deployed that in West Africa, to West African College of Surgeons, to see that our trainees also, to improve on the volumes, will go into the rural training centers, and they'll be able to offer services, at the same time develop competencies and confidence in practice. We haven't quite reached the point, but this is the direction we're going. We are hoping for the future that it will be possible for us, funds permitting, facilities permitting, to be able to utilize simulations in a much larger scale to ensure, and skills, to ensure that trainees will be able to, by the time they're going to touch a patient, they would have been, very knowledgeable, very practically, they would have known what really is done, and that will also shorten the duration in which they are being trained. If you are going to learn to do 20 hernias in 1 day, in 2 days, and you're going to take 2 years to do 20 hernias, certainly who is doing much more in a shorter time is going to acquire the skills better. So in the long run, we think that trying a solution we have preferred will be helpful. I think that every program has to be structured to meet the local needs and realities. And we are certainly going to discuss a bit more with you. And as I mentioned, we have another team from the Royal College of Physicians and Surgeons of Canada who will work with us in the concept of training some of our fellows in trying to get some skills in this area and transcribe to our various training centers in the sub-region. The president-elect of the West African College of Surgeons has just come in. Would you like to say something? Professor Dako, a little bit away. Are there other comments? Otherwise, I'll ask Dr. Marcos to address some of the questions and comments that were raised, having given you an overview of what the West African College of Surgeons is doing. Dr. Marcos?
Okay, well, that's a great conversation, and really it's quite relevant. I think we all have to recognize that what comes from the West is not necessarily right for Africa. There's a long history of that, right? So I think that really the ideas that we're talking about have worked in a North American or Western world concept, right? But you have to decide what works for you. These are ideas, and ideas can be applied in however it means it takes to make it work for your context. So I really think that what I'm talking about is not going to work for you. This is an idea that you have to adapt to your circumstance, and you're going to find your own way of doing it. And I think that's the only way it has to be. It has to work for different areas of Africa, depending on the healthcare demands, the systems, the trainees, the faculty. So this is just an idea, and it's up to you to decide what works best for your system. So. And I think you have the ability and innovation to do it. There's a lot of important comments here. I think the two main concepts I'd like to touch on are cost and time, okay? So with regards to, I'll talk about cost last, because the individual from Nigeria mentioned how are the systems going to afford this. But let's first talk about timing. First off, it sounds as though, and this is exactly what my colleagues from Ethiopia have stated. So I've trained the last two modern trained orthopedic trauma surgeons since the 1970s. So they're in Addis now, and all they deal with is pelvic and acetabular fractures for a country of 105 million people. One of them is the leader of the training program there, and he says, listen, Marco, he says, this is great what you do in Toronto, but he says, we now have 50 residents in our training program each year, and there are only 5 of us educators. How can we teach and assess 50 residents like this with only 5 trainees? They can't. So this is the issue that you're going to have in your countries, where you have to produce more to meet the healthcare needs of your population. I think that this idea of curricular change is innovative because it may allow you in your own way to turn around the training time for people you need to take care of the problems you have in your countries. It should not take 5 years of surgical training like it does in North America to train somebody in rural Africa to deal with common general surgical procedures. You may find with your own innovation technique that you can train somebody a lot faster. They don't need 5 years of North American training. What we do in North America does not relate to what you're doing here in many circumstances. You don't have CT scanners, you don't have MRIs, you don't have all the imaging that North America does and demands. You have to think about what works for you, and you may find that you may be able to turn surgeon trainings around a lot sooner to deal with the general healthcare needs of the population. Now, you're going to need subspecialists who need more training to deal with, for example, oncology or more complex things, but you may find different innovations that will make to save the time and save the cost. So, but only you can decide that. So I think that that's an important thing with regards to cost, because who's going to pay for this? Well, I think what the one thing you may find is that if you come with your own ways of making this work, you can go to your ministries of health and say, listen, if we invest a little bit of money to provide a better training program, it's going to save healthcare dollars down on the road because there'll be less complications to deal with. This is the problem in North America. We over-treat our patients. And when we over-treat our patients, they get complications. So our systems can't deal with complications. Canada's bankrupt. You think Canada's well off, but our healthcare system is not functional. It's bankrupt. So we go to our governments when they say this is too expensive, and we say, but if we train better surgeons, they're going to have less complication when they go into practice. It's going to save healthcare dollars. But you have to invest to show the difference. So right now we're working on a business model to the universities to show that this will be better. We have early data from our trainees that have graduated, but if we can show that they have less complications and they're more efficient, then that's healthcare savings. It saved the investment. How you make that work in your countries, you'd have to, you know. You have to advocate and work with your ministers of health. There's a lot of, it's all politics, right? But that's an opportunity to think about the investment for change, the return on saving of complications, and continue on in a healthcare system that may not be as effective as it can be. It's an opportunity to change, right? So I think that the main issue there is cost, and that would be my recommendation. Think of a business model to propose to get some investment and do pilot studies and see, does this pilot project work in this specialty, and then it can be applied to other specialties. The other thing with time, again, so if you can come up with innovative ways of decreasing timing to meet certain needs of surgical care in Africa, then you've done a great thing for your population and for timing. The other thing about the first comment from the individual from Guyana is about this is a great way of helping trainees remediate. Well, the whole idea of this is that you want to capture trainees before they take their exam. So if you can catch them early on in their training, They can become competent before they're set up to fail, so to speak. And in the old days, we'd send our trainees to the exam. They didn't pass, then we'd take them back and remediate them over 6 months or whatever. But in this way, you'd prevent them from getting there. And the benefit of this system is that if you're teaching and if you're assessing them more frequently, you actually may be able to get people that you know should never be surgeons. And we've all had trainees in our program who said they should never be a surgeon, but they get through. You catch them early and say, listen, we have all this feedback. Your motor skills are terrible. You're not ethical, you're not a good person. Go to a different training program or different specialty. And we've done that in our training program. We've actually caught a few trainees that, nice people, ethical, good people, but they could not operate. They couldn't operate through a wet bag. They were terrible technicians. Took them many years to see that because we kept on remediating them, but ultimately said, look at yourself in the mirror, you can't be a surgeon. And off they went, okay? So it saved society the problem of having a bad surgeon out there. That person would have passed the exam. An oral and written exam in our nation's capital is easy to pass, but taking care of patients is a different thing. So the benefit of this is it keeps trainees from becoming surgeons if they shouldn't be, because you capture them, keeps them from going to the exam so you don't have to remediate them. But it's time and effort from your faculty, and only you can decide what's going to work in your jurisdictions for that. And again, it sounds like in Africa you have many more trainees than you have faculty. So how you're going to make that work is up to you to decide. It's a tricky one. But I think, again, you know, there's an opportunity here for cost savings, but you need investment, and you need your faculty to be on board. And I think once your faculty are on board, again, it's a generational change. You know, as you mentioned, how do the trainers pass this to the trainees and the individual from Nigeria? Our faculty have been doing it for 10 years. They still don't have all the ideas straight yet. So it's going to be generations before this takes effect. And again, what works for us is going to be different from you. You need to get your first group of trainers involved and interested, and from that they'll spread. You know, then you'll get, and then the next generation of trainees will say, I was trained in that way, and they'll pass that on. And there'll always be variations. The key thing here is you can't say this is it, black and white. You have to be responsive for change, and you'll get feedback from your faculty and trainees to modify it for your own, the way it works in your own country and your own jurisdiction. You need feedback to keep it working, because everything in medicine has to change and adapt for the betterment of our patients. So it's a complex thing, but I think this is politics, this is business, this is social, this is cultural, and it's, you know, medical science. So that's what I like to say. But your comments are right on, and they really show your diversity of opinions, and I know you're going to be able to do it. It's just making sure it works for you. But it's an idea to consider. Again, you decide what you want to do, and but we'd be happy to help. And it sounds like you already have an affiliation with the Royal College, so but hopefully it's food for thought. Thank you.
Thank you very much, Dr. Marcus. Can we put our hands together for Dr. Marcus? Very wonderful. Marcus, for a very wonderful presentation. You stimulated us, and I can tell you the discussions will continue outside here. And like I said, we actually have an MOU with the Royal College of Physicians and Surgeons of Canada, and a number of people will be coming here. Some are already on ground to also deal with these competency-based issues. So we certainly will be back with you, formally and informally. I'd like to thank the audience for very lively contributions. If all the questions have not been addressed, we can still talk about that. It's a continuing discussion, and I'd like to thank the Director General for spending time with us despite a lot of things she has to do in the office. She joined us here, and thank Professor Fru Angofu, who served as our impromptu moderator, rapporteur, to ensure that all of us are on board on this discussion. I think we should put our hands together for all of us for making this session a very lively one. This session comes to a close now.